Hi, everyone, and welcome back to the podcast. This week, I have a special guest on the show, Dr. G. Tranise, welcome to the show.
Thank you so much, Kate. Kate, I really appreciate you having me on.
Well, I'm excited today. I haven't talked much on the podcast about our heart health and cardiovascular disease, and it's clearly, a very important topic and, one of the, or if the leading, cause of death in the world. So before we dive into all that, can you just introduce yourself to our listeners?
Certainly. So my name is Tranise Goodlow. I am a cardiology nurse practitioner, a medical science liaison, as well as an entrepreneur and professor.
Wow. So lots of, hard work and degrees and qualifications there. So when it comes to our heart health, what do you want or what do you hope people know?
I think people need to understand that you have to take it seriously. I think a lot of times if we don't see something or feel something necessarily, we just assume that everything is okay. And that's not really the case. One example I can give is hypertension. That's known as a silent killer. A lot of people are walking around hypertensive and they don't know it because it many times can just be asymptomatic.
Mm. And is it, I think most people, especially, my clients that I work with, nobody tends to really think about their heart health in their 20s, 30s, maybe even 40s. It's only if they get some type of scare, or they go to the doctor and they have their blood work done and their doctor goes, oh, look, your cholesterol's a bit too high or your blood pressure's high. Maybe we should start to look at their heart health.
Right, absolutely. Really kind of with anything in healthcare, not even necessarily heart health, but just life in general, the more proactive you are, the more likely you are to have a handle on the situation. People ask me all the time, when should I worry? When should I look at it? I hate to say it, but as soon as you are really cognizant of it, I would even say high school age, if you're becoming a young adult, that's when you need to be aware of your parents' health history, your grandparents' health history, because these things tend to be patterned, right? So I'll give an example. If I have a patient and say everybody in their family has literally had a heart attack, well, that puts you at risk for a heart attack, so that we need to be proactive in that. So waiting until you're 50, when everybody, if say everyone in the family had a heart attack at 55, well, coming in at 50 saying, oh, everybody had a heart attack at 55, that's not very helpful. We can still treat the person, but it's much easier when you're a young adult, you're 21, right? You're out on your own, you're going to your annuals and you're telling your provider, hey, everybody in my family in the 50s had a heart attack. How are we going to have that not happen to me?
Over here, sometimes people don't have a regular doctor, so they will just see whoever's on, and it happens all the time. Like they think that they don't need to have a regular doctor. So, is it important to have that rapport, and then obviously they're recording histories, but maybe sometimes that can get lost. Is that relationship with having a regular doctor super important?
To answer your question emphatically, yes. You build relationships, you build bond, you build trust with people over time. There's patients that I could recall their history just like that because I know them that well. That's what you want out of a provider. Um, we have to get out of this mindset of I'm only going to go see someone when something's wrong. It's sort of like I'll use the analogy of your car, right? You're supposed to get your oil changes. You're supposed to get your tires rotated, right? You could be driving and nothing is wrong with the car, but it's just time to, you know, get it tuned up. And so we are machines, right? We're human, but we're kind of wired in that sense. So it's very, very markedly important to not have this, oh, I'm only going to go see someone when I'm feeling bad kind of attitude, and be proactive, because it just makes your care a lot easier. Imagine catching I'll use the hypertension example again. So imagine someone walking to the office and someone's blood pressure is 200 over 100. It's like, oh my God, your pressure's so high. But imagine that same person, if they would have came in and it was maybe 135 over 80. Well, that's still hypertensive, but it's a marked difference between 135 and 200. And so at that stage, we could probably talk more about lifestyle modification, and seeing if we can get something on board before going to medicines. Versus if you're coming in that acutely high, that's going to have to get treated with medicines. So,
Well, it's obviously, it's going back to that prevention is better than trying to work with the cure because, as you said, if you can prevent it early enough, then the steps, that you can take to then, stop something from occurring can be a lot simpler, maybe a lot cheaper than, at the end stages.
absolutely. Absolutely.
Now, when it comes to our heart health and things we should be thinking about and focusing on, what are the main sort of areas that you hope people can, listen to this podcast and then go off and start to think about and instigate?
So within the healthcare community, we have something called modifiable risk factors and non-modifiable risk factors. So non-modifiable risk factors are things that you have no control over. For example, you have no control over your family history. That's non-modifiable. You have no control over your gender. You have no control over your age. It just is what it is. But modifiable risk factors, those are things you have a direct hand in. For example, if you are a smoker, that's modifiable. If you drink alcohol, that's modifiable. If you exercise, that's modifiable. Your diet, that's modifiable. So those sort of things, I would tell people to really focus and hone in on the things that they can control, because that's going to have a better long-term outcome for you. Because again, like you stated, prevention. So if I have a 50-year-old who runs 2Ks and eats a low-fat diet and doesn't drink, versus I have a 50-year-old who smokes, is sedentary, and goes to the bar every Friday and Saturday night. I mean, you tell me who's at a higher risk of having a problem.
Yeah. I'm saying most people listening in can probably guess which one's going to have the higher risk anyway. Now, when we talk about there's heart disease, there's heart attack, there's stroke, I think that can get confusing for people, what each one is. Can you explain the differences between them? I'm sure this is probably a question you get asked a lot.
Sure. So heart disease is a broad general term that really has to do with anything in the heart and the vessels specific. So examples of heart disease would be coronary artery disease. So if the arteries in the heart are clogged, you can have people that have structural heart disease or something wrong with their valve. You can have people that have heart failure, meaning the main pumping chamber of the heart is weak and blood gets backed up, because if it's weak, blood either goes forward or backwards. So if your pump is weak, it's going to go backwards. So those are examples of what heart disease is. Now you mentioned stroke. So stroke is under the umbrella of cardiovascular, because stroke is a vascular event, but it's in the brain. So all a stroke means, actually, a stroke and a heart attack are actually very similar. It's just blockage. It's just in the heart attack, the blockage is in the heart, and a stroke, the blockage is in the brain. But the same basic principle.
Yeah. And I'm assuming too that do they have varying risks, or is a stroke a little bit less bad than a heart attack, or are they all, do you know what I mean? They're all life threatening. So, but I know I've
Yes.
had clients come in, and my dad even, presented at emergency, and he had I'm going to get it wrong, a TMI.
TIA.
Yes, that's it. TIA.
TIA.
So
Transient ischemic attack. Yes.
exactly. So, but it wasn't not classified as a stroke as such. So, can you delve into that a little bit too?
Yes. So TIA stands for transient ischemic attack. And so basically it is a length in time in which the brain isn't getting enough oxygen. So ischemia, that's what we call ischemia. And so the difference between that and a stroke is really the time frame. So a stroke is like longer, right? But the TIAs have also been dubbed mini strokes in the medical community. So if you will, a mini stroke. So it was transient, and then he regained his function and symptoms resolve and whatnot. Whereas a stroke, and again, there's levels to this, right? There's such thing as having a mild stroke. There's such thing as having a severe stroke. And same for heart attack. You can have, nobody wants any of this, but there's a big difference between having a smaller heart attack versus having the widowmaker, right? And it's called Widowmaker for a reason. So it's levels to it, of course. But the basic principle in each underlying etiology is oxygen cannot get to where it needs to go. So I question patients or my students or anyone I'm encountering, what can we do to preserve oxygen going to your brain? I mean, that's a big deal. Oxygen to your heart, right? So that's where those modifiable risk factors come into play.
And when it comes to, diet and lifestyle, is there a hierarchy that you sort of get people to look at first? So do you get them to start with the diet first and then look at the exercise and then maybe look at stress and so on and so forth?
I love that question. I love that question. And let me tell you why. Um, when I was seeing patients, in my current role, I don't see patients, but when I was seeing patients, my plan for the patient was the patient's plan. What I mean by that is let's do another imaginary patient. Let's say there's a 45-year-old woman. She smokes, she drinks, she's sedentary, she eats McDonald's every day. Okay. And she has a high stress job. Okay. So that's 5 things that are very bad. If I had a patient like that come to me, my question would be, Mrs. So-and-so, what is the easiest thing for you to change? Because the thing is, as a provider, even though some people may think of it this way, I'm not a judge. I can't sentence you. I'm a consultant. You basically hire me to consult on your health and we get you on the right track. So for her, it might be smoking. She may say, out of those 5 things, the thing I could probably cut back on is smoking. Another person may say, well, no, it's the drinking. So I let the patient decide, because you get better compliance and you get better buy-in when I follow you instead of me trying to drag you along what I want. It doesn't matter what I want. I want what you want. So I want to make it as easy and as seamless as possible.
Well, I think that's, like you said, you're going to get much better compliance from your patient rather than saying, okay, we're going to overhaul your diet completely and you now have to eat this, this, and this. And they take the piece of paper from you and pretty much walk out and throw it over their shoulder.
Yeah, a little bit more on the diet piece. I've always tried to compromise with people. I remember one patient in particular, he told me that he ate ice cream every day. Every day. So I asked him, I didn't even really ask about the rest of the diet, but he was a big ice cream person. So I was like, is there any possible way that you can maybe cut down ice cream 3 to 4 days a week? Like eat it every other day, not every day. And he looked at me, he's kind of like, yeah, I could probably do that. So even those are small wins though, right? Like obviously you shouldn't be eating ice cream every other day either, but at least we're putting him on the right track. And maybe the next time I see him, maybe can you just only do it 2 days a week? I mean, small steps are still steps in the right direction. We have to remember that. Sometimes people get impatient with the process, but you can't. As long as we're making progress, we should all be happy about that, no matter how slow that progress is.
Yeah. And I think that's probably a good reminder for people listening in that they may have a loved one that's gone through this and they may be like, well, how come your doctor didn't say you should be cutting out this and cutting out that? And, they probably think, this is not quick enough. You've had a life threatening, disease or event. So I guess that's probably good advice for them just to sit back and sort of realize too that if it's just a small progress but it's happening over time, then there are going to be results.
Well, absolutely. And to not to belabor the point, but let's be real here. If we have a patient who, let's say someone had a heart attack and they had all the things I said, the drinking, the smoking, the ice cream, let's say they're doing all of that. So if we change that one thing, they're already better than what they did before the event, you know? So we have to give credit when credit is due. And this is a journey, right? This isn't an instant thing. Like this is going to be a journey to get to that destination of health. So
Yeah. And if people are listening in and thinking, okay, well, I do want to focus on, eating foods that are going to, protect my health and hopefully ward off, any heart disease, what types of foods should they be focusing on?
So I will say in the States here, there's 2 diets that are recommended, either the Mediterranean diet or a heart healthy diet. Now, they both have some similar qualities. The heart healthy diet has more about with salt, lowering salt, not to have more than 2,300 milligrams a day. But sometimes I like to frame it as, and again, not to sound restrictive, but what should I like stay away from? Sometimes it's easy to figure out what should I not have versus what should I be doing, if that makes sense.
Yeah.
So, for example, I probably shouldn't be eating pizza, right? I probably shouldn't be eating ice cream. I probably shouldn't be eating cheeseburgers, right? Even just starting there, because all those foods I listed, they're high in fat, they're high in salt, they're high in sugar. And that's what the Mediterranean diet is: low in sugar, low in fat, or at least having healthy fats, olive oil, avocado, those sort of things, staying away from chips and saturated fats and those sort of things. So I guess I'm kind of saying the same thing, but two different ways. So you could look at it as what diet should I follow, or what should I not be eating right now? Like,
Yeah.
is this a good choice for me?
And I think, you made some good points of just generally looking at, a lot of our processed foods tend to be high in fat and sugars and sodium and those types of things. So if we can, cook at home, or, look at an option that's got more whole foods in it rather than the processed foods, then, overall it's going to be better for our health.
Yeah, and to add another point, some patients would joke with me and say, "Well, I can't be perfect. You want me to eat this Mediterranean diet?" And full transparency, I would tell my patients, follow the 80-20 rule. And what I mean by that is 80% of the time you are compliant and doing what you need to do. 20% of the time, enjoy your life. Now, if that doesn't apply to smoking, I'm speaking strictly of the diet piece. But enjoy your anniversary, enjoy your grandkid's birthday, enjoy life. Life is meant to be enjoyed. But the problem is you can't indulge. Your life shouldn't all about indulgences. So if you're eating ice cream every day, you're indulging every day, and that's putting a toll on your heart and your health. Another point I'll make about the diet is this. I've had patients tell me, I'd love to do what you're saying, but the healthy food is just so expensive.
Yeah.
And and so I agree. I said, you know what, you're 100% right. You will get no argument out of me that healthy food is more expensive. Okay. However, healthy food is not more expensive than having a heart attack. Healthy food is not more expensive than having an amputation and you don't have a leg anymore. Healthy food is not more expensive than you having a stroke and you lose half of your body function on one side of your body and you can't drive anymore. So putting it in perspective, life is expensive. No matter how you slice it, it's expensive, but choose your hard. I tell my patients all the time, choose your hard. It's hard to be healthy. It's hard to go to the gym. It's hard to be disciplined. It's hard to be sick. You got medical bills. You got, you can't move. You can't breathe. You can't do. So we have to choose our hard is really what it comes down to.
Yeah. And as you said, if you don't have your health, you don't, you can't go out, enjoy other things. You can't work to earn the money, to pay the bills, to all the rest of it. So our health, it's that integral part that I think we all take for granted until we don't have it. And then we realize how hard it is when we don't have it.
Absolutely. The world stops, right? If something happened to you today, health wise, that was catastrophic, your whole world would stop. So it's the most precious thing we have. And that's why I tell people all the time, it's such an honor and a privilege to do what I do, to have people trust me with the most valuable thing that they have. I don't take it lightly. I take it very seriously. And even to educate people on their health. It's something I enjoy doing, and I'm honored and privileged to do it, just like I'm honored to be sitting here with you and you even having me on. So, just thank you to the patients. Thank you to you, your platform, everything.
Well, I want to talk about too our exercise when it comes to, moving our body and our heart health, because I think there's some confusion. I think most people know that they need to move, but they're not sure how much they should be doing, how intense it should be, and what type of exercise they should be doing. So can we delve into that too?
Oh, yes, absolutely. I know you're in Australia, so if the powers that be vary a little bit in America, but I'm pretty sure this will be similarly aligned. The American Heart Association has come up with some I don't want to say guidelines, maybe I'll say recommendations. So, for example, we all should be getting 10,000 steps a day. Now, that's roughly 4.5 miles. Now, obviously, if you're not accustomed to doing that, no one's saying, oh, you only walk 1,000 and I'll go up to 10. No, you incrementally go up. Another thing is exercise. What constitutes exercise? You asked me about that. Well, let's talk about that. So the American Heart Association recommends that everybody get 150 minutes of moderate exercise per week or 75 minutes of vigorous exercise. So let's define moderate and let's define vigorous or high intensity. So moderate would be walking 2.5 miles per hour. That cadence, that would be something moderate. Gardening would be considered moderate. Those sort of activities. Vigorous would be something like running. Running is vigorous. Hiking up a hill, doing interval weight training where you're kind of moving around a lot. So that would be your quote unquote definitions and examples of what is moderate exercise versus what is considered vigorous, and then the 150 versus the 75 per week.
Yep. I think, hearing 150 sounds like a lot for a lot of people like listening in. They're like, 150 minutes of movement. How am I possibly going to find the time to fit that in? So, what do you suggest? If you've got a patient in front of you that's like, I work, I've got kids, I've got parents I've got to help to look after. How am I going to fit this movement in?
Absolutely. I think you have to be creative. For example, if you're working from home, I have one in my office under treadmill desk. So there's calls I can be on, I'm walking. So I'm getting it in and I'm not even realizing it because I'm on a call. Okay. Another example would be is say you and your spouse at the end of the day, you guys eat dinner, you watch a little TV, you get in bed. Don't do it too close to going to bed because you really shouldn't exercise too close to going to bed. However, what about going out in the neighborhood and taking a walk instead of watching TV? And then you're talking. I find that if you do exercise while you're talking, you tend to not realize it. I'm a big component in, oh, let's go walk and talk, because you're doing it and it's just, it's effortless. So getting creative, a lot of people have pets. You have a dog, you've got to walk the dog. Okay. Children, well, it's springtime. It's coming up on spring here. I'm not sure what season it is in Australia, but it's sort of like, oh, well, let's go outside with the kids. Let's take them to the park. Let's do that. Let's be intentional, right? People say, oh, if the weather's bad, okay, you can join a gym, right? Like if you really want to do something, you will find a way to do it. And I find that people who in general don't exercise, they don't have the will to do it. They just don't. People figure things out all the time. I don't know how to do this, but I'm going to figure it out. Very determined, right? But it's kind of like a little bit of a cop out. Well, I don't have a treadmill, so
Yeah,
it's like,
I can't
okay,
do
go
it.
walk outside. Yeah. Right. Buy one.
But I think too, it comes back to sort of what we were saying before, that we have choices to make. And even if we, maybe we don't love, exercise, maybe we hate exercise, but there's something that you would enjoy, maybe you don't like walking. So maybe you can try yoga, or, you know what I mean? There is options. It's just taking the steps to ensure that you have to follow through, because as we said before, life can't always be about indulgences. If we want to be here for a long period of time, there's some hard stuff sometimes that we have to do even though we might not want to.
Yeah, absolutely. And to kind of add on what you're saying, exercise releases endorphins and feel good hormones, right? So, and there's other things you can do. For example, listen to music. You enjoy music, you kind of get into the music, you don't realize it. So I think that people sometimes underestimate habits, right? You can have good habits and you can have bad habits. And just like somebody may have the habit of going down to the bar every Friday, Saturday, and Sunday night, that's a habit, right? Like muscle memory, like that's just, I do it just because that's what I do. Well, you can still do that with exercise. And again, just to be clear, we're not asking people to go be bodybuilders here, okay? Keeping your body fit for life, right? To enjoy life and feel good. It doesn't feel good to be 300 pounds overweight. It doesn't feel good to be short of breath because you got up and walked from the couch to the bathroom. And I find that the real issue is forming the habit. Don't fall out of the habit. I'll use myself as an example. So I'm a former athlete, basketball player, and right now I'm actually training to be an amateur power lifter. And so I've had a slew of injuries. I've had 5 knee surgeries. I've had a ruptured Achilles. I've had a major pelvic surgery as well. Many, many injuries. But I always knew, and maybe it's because of my education and my background, I had to tell myself, Tranise, you cannot let this stop you. You will kill yourself, literally, if you say, oh, I'm laid up, and I just continue to be laid up. And diabetes runs in my family, and hypertension, and all the things, right? So you have to take a good hard look at yourself and say, what do I want my life to be? What do I want to be? Do I want to be another statistic? Or do I actually want to put forth the effort to feel good, look good, do well? And just the privilege. Exercise is a privilege. Shifting your mind. Oh, I have to. No, you don't have to exercise. You don't have to do anything. You get to exercise. You have a body that's able to walk. You know how many people would kill for that, right? You think about people that have maybe been in catastrophic car accidents or paralyzed that would just kill just to be able to walk. And we take it for granted. We can't take this for granted. Like we can't.
Mm. And I think that mindset shift is super powerful. Like just saying it like that, I hope people listening, because I just went, I'm super grateful that I can move right now. And, hearing that and then going, okay, well, what can I do to start today? And even when, we were saying before, 150 minutes sounds like a lot. When you break it down over 7 days, it's only like just over 20 minutes a day. So out of 24 hours in your day, we just want
Mhm.
you to move for just over 20 minutes. And you could break that down and do 5 minutes here and 5 minutes there. So looking at what will work for you and, realizing that out of 24 hours, 20 minutes isn't that much really.
No, I love the way you broke that down. It's genius. You could get 10 in the morning and 10 in the afternoon and be done.
Yeah, that's it. So when you think of it like that, it's quite simple to do. But when you look at it at the whole picture of 150 minutes and think about how busy your week is, that's what can freak you out. So yeah, just really trying to chop it down and look at those small steps. And as you said, forming those habits, stacking those habits, putting it, maybe you go for your 10-minute walk after you've, had your morning coffee and fed the dog or something, so that you stack it one in a row and it just feels like the normal routine in the morning.
Absolutely. I'm laughing because I think about some of my former patients and they ask me about like, how are you able to exercise? How do you fit it in with all that you do? It's ingrained in me. It just is. And again, I'm privileged because I have an athlete mentality. I played ball since I was 5 years old. So that was always in me. But for me, and I teach my children the same thing, exercise is part of life. Like you get up, you go to school, you go to work, you do your taxes, life things. I'm teaching my children that exercise is a life thing and you get to do it and you need to feel blessed and fortunate to have a body that's able to do it.
Mm. And it's prioritizing your time as well, isn't it? It's really choosing what your priorities are. And if your health is your priority, then, the food you eat, how you move your body, managing your stress, sleep, all of these things need to be priorities in your life. Otherwise, health isn't the priority.
I couldn't have said it better myself. Right on. Right on.
Now, we often hear, or people listening may have had a friend or a loved one where they've passed away from a heart attack. And I've had clients say it to me, they were 45, male, not overweight, exercise, seemed to eat pretty well, and it came out of the blue. What experience do you have with those types of cases?
I can say, fortunately, I haven't had many of those. Um, one actually comes to mind, very similar, but the person was actually even younger than that. He was in his 30s. And sort of like we discussed the risk factors, the cut and dryness of it is bad genes, bad anatomy, bad genes. So there's a saying that some healthcare professionals use, and I'll say the saying right now. Genetics loads the gun, but lifestyle pulls the trigger. And unfortunately, if your genetics are so bad that people are dying in their 30s and 40s of heart attacks, that's going to be very, very difficult to escape without, one, having preventative care, which there's some cool stuff going on with cholesterols right now. If we have time, I'll dive into it. There's some cool stuff with cholesterols. But again, it's never too early. I know some of your listeners may think I'm, being dramatic about this, but seriously, like, your kids or teenagers, like, talk to them about health, get it on their radar. I remember being a senior in high school. I was 18 years old. We had a pathologist come to class, and she had different body parts, but I was enamored with this heart that she bought, and she cut it in half. We saw the arteries and everything. She said, "This is what a heart looks like of somebody who ate McDonald's every day." It was hard, thick, clogged, and I'm an 18-year-old kid, right? I'm eating McDonald's like it's going out of style, right? But when she came, she had such an impression on me that I stopped. At 18 years old, I had the foresight, so that really shook me to my core. Like, I can't do that to myself. So, like I said, unfortunately, some people cannot get past the genetic component. But like I said, healthcare is advancing, and there's some really, really cool stuff that's coming out.
Well, let's dive into cholesterol, because I wanted to take the conversation to blood pressure and cholesterol anyway. So share with us some of the amazing things that are coming out with cholesterol.
So one of the newer drug classes is called PCSK9 inhibitor. There's 2 drugs on the market right now, Repatha and Praluent. And so what's interesting about that is they lower your LDL, low density lipoprotein. That's the one we try to attack. The lower, the better. Here in America, for when I say a normal person, someone with no heart history or anything, you want it to be under 100. If they are diabetic or have some kind of history, under 70. But in Europe, they want the general pop under 55. And if you have an issue there, it's under 50. Now, we're born with an LDL in the 30s. Of course, I'm not quite sure what Australia's numbers are, but the point is, the lower, the better. So I mentioned the PCSK9 inhibitors because those lower LDL, which is great, okay? But they also have been shown to lower something called Lp(a). And so Lp(a) is very, very interesting. Now, it's not clear if those medicines, they lower Lp(a), but does that improve the patient's outcome? That's not clear. They improve outcome on the LDL side, but not the Lp(a) side. So Amgen, and Amgen makes Repatha, by the way, but Amgen is in phase 2 trials right now for an Lp(a) drug. The reason why Lp(a) is so exciting is you can draw Lp(a) on a baby. So imagine being able to do that and say, this child is at risk for having cardiovascular disease. So we've just shifted the narrative, right? Like, at least over here, a lot of times people don't get treated for cholesterols unless we use a scoring called an ASCVD score. It's a bunch of numbers you put in and risk factors, and it spits out a score. And if it's over 7.5%, it's recommended to put them on cholesterol medicine. Generally statins, but there's other things going on. But could you imagine if Lp(a) was drawn and we could start cholesterol medicines sooner so that we're preventing the clogging from happening? And then cardiovascular disease is one of those things that is even more advanced in life and not happening in midlife. Like, it's just super exciting to me.
Well, even just then looking at like building the awareness in the person too from a much younger age as well, that you are at higher risk. So therefore, straight off the bat, if you can teach them, healthier choices and things, then that may have effect just lifestyle wise too.
Absolutely. I think you bring up a really interesting point. I'm going to give another example. It's a little off the wall example, but I'm going to give an example. So my husband and I, we have 3 boys. And when I was pregnant with our first son, I told my husband, I want them all bilingual. I want them speaking English and Spanish. And so he was down for it. And so now my boys are a little bit, they're still young, but just, a few years older. And so I've mandated in the house on Fridays, Saturdays, and Sundays, I only want to hear Spanish. And so my parents, his parents think it's a little strange, and they're like, why are you doing all this? Well, one, bilingual children, you tap into different portions of the language in the brain, do better on standardized testing. You can speak to more people. They're more culturally accepting. But it's not even that. It's this. As a parent, I dictate what is normal, right? Their perception of normal is based off of what I give them. So to tie it back to the cholesterol piece and the health piece and what we're talking about, I think it's very important if you're drawing these Lp(a) on children and figuring out where their spectrum is and all this, setting the new standard of normal, right? Saying we're going to exercise, we're going to eat right, because they're kids, right? Oh, okay, that's what they said. Okay, but you run into problems, right? If you're letting, at least my kids, if I let them do whatever and I come back and try to tighten it up, it's like, well, we used to do it this way. Why are we doing it this way? And you get that resistance. So I think within the healthcare community, patients, providers, all of us have to do a better job of setting the standard of normal. This is not normal. We want you to live and grow and flourish. So how do we put this new normal so that it's not so much angst and work?
Mm. And if you are starting with kids young, and then they develop those habits and then they grow up with those healthy habits, then they have kids and they pass it on. And then, you have this flow on effect. And hopefully we see these diseases decline in a perfect world.
Right.
Unfortunately, we are seeing a lot of these diseases increasing more than ever. So can you speak a little bit about that as well?
Yes, it's, as a healthcare professional, it bothers me, and it frustrates me. I'm going to say something that might be a little controversial. We'll see how well received it is. As a healthcare professional, I only can do 2 things for a patient. I can order a medication, or I can have you do a procedure. That's it. I don't have any options. So as a healthcare professional, it's difficult when you're trying to talk about lifestyle and, all these things, and you meet resistance. And then so you say, okay, well, if you don't want to do that, then we're going to have to do the medicine. Well, I don't want to do the medicine either. Okay. You have to give, right? So I always say, we only can do what we can do, but at the end of the day, there is some patient responsibility, right? You have to come in understanding that you have to, well, you don't have to, but you should be doing something. If you walk in my office and you have a blood pressure of 160 over 100, what exactly do you think is going to happen? Do you think I'm just going to say, oh, well, that's okay, see you
Bye.
in a few months? Right. Like, what do you think is going to happen? So I think managing patient expectations. I will also say this as a provider in the healthcare community. It's easier to not give medicines. You have to realize when you prescribe a medicine, you're responsible for that. I have to monitor the medicine. I got to draw blood work. I have to, you know what I mean? Like it's work. So I think sometimes there's this misconception in patients that, oh, they just gave me a pill. It's like, no, now I'm responsible for that pill and how you react to it and managing it and make sure you do well on that. So I guess what I'm saying is I would like patients to kind of meet halfway, right? Come in with the mindset of, okay, so they found something wrong. They're going to do what they got to do, but I have to do what I have to do. I have to meet them in the middle. They can't do it all and me just sit back and be like, okay, they're just doing this. No, you got to meet us in the middle. We'll get a better result. We will get a better result.
Well, I agree with you 100%. Like, there comes a point where the patient needs to take responsibility. So even if it's up to that point, maybe they didn't have the knowledge around that, but then they've seen you. Now they have the information, they have the options, they have the choices. Then it's up to them to take those steps. Like as you said, you can only do so much, and then they've got to then take those steps. Otherwise, it's just not going to change the outcome, is it?
No, it's not. And it really makes me sad when I see patients. Um, Everyone has to do what's best for them in their personal situation, but I'm in the business of wanting people to live long, healthy, full lives. And the fact of the matter is, no one, when I say no one, I mean no one is going to get out of this life without having coronary disease. We all have coronary disease. You can't live 80 or 90 years and not have any plaque at all built up in your heart. The question is, will it be your demise? Right? So if you have an artery that is 90% clogged, that's coronary artery disease. You're probably going to need to get stents, go to cardiac rehab, do the whole bit. But there's people that's not their demise. Say you died of pneumonia and said they did an autopsy on you, might only have 20% disease. Well, that's not enough to do anything. So and that's why I tell patients, it's not about being perfect, it's about being better. Let's avoid premature plaque. And the way to get premature plaque is the smoking and the drinking and the eating and the inactivity and the stress. All of that is how you get it premature. And then if you have a bad family history, that's just a ticking time bomb.
Mm. And when it comes to our risks in relation to gender, is there any difference between male and female?
Absolutely. One of the major differences is presentation. Um, the classic heart attack signs of pain in the jaw and elephant on my chest and sweating and all of that. And typical in men. Now, that's not to say a woman can't have those symptoms, but that's like the typical presentation you think of when you think someone having a heart attack or an ischemic situation going on. Women can have an atypical presentation. So I give an example. I had one patient, her only symptom was ear pain. It was her heart, ear pain. Another client, tooth pain. Sometimes women can feel like they have indigestion. Sometimes they just feel really tired, just kind of like a general vagueness, but just like, I just don't feel right. Like really hard to put your finger on. So that's one difference, is the presentation. Another difference is men are at risk earlier in age than women. And there's different articles and research done on this. Some thought is that women get an increased risk because of estrogen, or I should say lack thereof. Meaning the younger you are, the more estrogen that protects you from having situations and whatnot. It is different. We have to be very mindful of it. So when I have a woman in particular, I have less tolerance. I know you asked about gender, but I'll mention one other thing that's true for both genders: diabetics. Diabetics are notorious for having atypical presentation. Diabetics are at risk for something called a silent heart attack. Now, you could imagine that is the worst kind of heart attack you can have, because no one knows you're having it. You don't even know you're having it. So that's because diabetes, the sugary blood, damages the blood vessels throughout the body. It damages the nerve endings too. So a diabetic can't manifest pain like a normal person because of the sugary blood damaging those vessels. So diabetes is one of the worst, if not the worst. I had the pleasure of working with several cardiologists in my career, and one of them told me, we were just chatting one day, he said, if I had to pick the worst comorbidity for a patient to have, it's not smoking, it's not drinking, it's diabetes. Diabetes is inflammatory throughout the entire body. So again, that goes back to lifestyle and eating and what's your family history and that sort of thing. But yes, that's what I would say on the gender piece, but I just wanted to throw the diabetic thing in there as well, because that is an atypical presentation.
Well, that's really interesting. And I know here in Australia, a lot of people will get told that they're pre-diabetic, So, they're not quite at the need yet for medication. And, so they just go about and they say, oh, but I don't drink much and I don't eat much processed food and I don't have much sugar. So I'm not really, it just must be genetic. There mustn't be anything else. So there's not really much I can do about it. But what is your sort of suggestion that if someone's sort of been diagnosed as pre-diabetic, where can they start looking to make a few changes?
This is a great question. I enjoy that question. So a couple of things. Obviously, I look at things in the lens of cardiology. So I'll just say this. In cardiology, we don't believe in pre-diabetic. It's either you're diabetic or you're not. And I'll give this example. It's kind of like being pregnant. You're either pregnant or you're not. You're not pre-pregnant. You're not kind of pregnant, right? You're either pregnant or you're not. So if you come to us pre-diabetic, we're going to consider you diabetic and at an increased risk. And there's a whole set of other things we do, like we usually get, particularly if they have coronary disease, we'll get stress testing more often because we know diabetics present atypically and whatnot. But to answer your question about what can they do about it, it's not impossible, but in general, people that are pre-diabetic, in general, there's always exceptions to everything, are overweight. In general. So losing weight. But I would say the crux of it would be the diet piece. Because diabetes means you have high blood sugar. So you're having too many simple sugars, simple carbs, whatever. Examples I used to give my clients. Instead of eating mashed potatoes, that's a simple carb. You want to eat sweet potatoes. That's a complex carb. Complex carbs will keep your blood sugar even more often. Simple carbs jack you up high and then take you down low. You eat again because you're low. You got to eat something. Bring you back high. You have these peaks and these troughs, and those peaks are making you pre-diabetic. So understanding what are you eating? Hey, I didn't realize that was a simple carb. I didn't know that was happening. So, doing a little research, and you could really find some of this on the internet, right? What is a simple carb? What is a complex carb? So that would be my recommendation.
Yeah. And I think too, sometimes just looking at the portion sizes you're having too of certain. So, if half your plate is mashed potato and you've only got one little side of veg and, a bit of a steak, well, maybe cut down the amount of mashed potato and fill up with some nice green veggies and then, increase your portion of protein as well.
Well, you bring up a good point because vegetables are high in fiber, which makes us feel fuller longer and also stabilizes blood sugar. So absolutely. Absolutely. Right on.
So, coming to the end, if, you could leave listeners with just one piece of health advice around their heart, what would it be?
Again, a little controversial, but I'm going to state this because I think I beat the dead horse of be proactive. I don't want to say, oh, be proactive. I've said that too many times. I believe patients should demand, I don't know how it is in Australia, but in the States, it's not happening. Demand an EKG at their annual visit. I think they should demand it for several reasons. Number one, we're just talking about heart disease, number one killer. So that in and of itself, people should be getting screened. But outside of that, here's really why I say this. Being in cardiology, I can't tell you how many times we've had people come in, oh, he's having chest pain, oh, he's having palpitations, he's having something. Okay, give me a previous EKG to see we don't have one. We mean we don't have a previous EKG. So unfortunately, sometimes that's not gotten. Sometimes it's a money issue. Sometimes it's the provider may not be comfortable reading EKGs. So I always say to anybody who listens to me, like I said, it's a little controversial, but get an annual EKG. Think of it like this. When would you ever get an EKG in your life?
Well, generally here, you wouldn't. You'd only get it as if you had if you had something happen, then they might order one. That would be it.
Right. You wouldn't. So seeing your primary care provider That would be the only time a quote unquote healthy person or a normal I shouldn't say healthy, because you may have other things. You may have fibromyalgia, you may have a liver problem. What I'm saying is that's the only time that in your life that you're going to get an EKG unless you already have a cardiologist. So how do we know you don't need a cardiologist? Right? Hypertension is a silent killer. There's silent heart attacks. There's all these things that people are at risk for. So my advice to your listeners would be is demand an EKG at least, you need one at least every 2 or 3 years, at least. I get one annually. I don't have any heart problems, but I get one annually. That way, if something were to happen, or they say, or actually I'll use my husband as an example. We had an annual, his EKG came back abnormal. I didn't get to see the EKG. I'm like, why didn't you let me see it? You know, I can read it, but that's neither here nor there. So he's like, they want to get some kind of test on me or whatever. They ended up getting an ultrasound of his heart and it came back looking fine. But that's my point. If that provider wasn't diligent enough to have gotten that EKG, he'd be walking around with an abnormal EKG that nobody would have known about. Then if something happens to him, how do they know what it is? So just get an EKG. That would be my advice.
Yes, well, it's definitely not standard here. You'd have to request one. And if you didn't have a reason for requesting one, they'd probably say no. Because again, it's time and it's money. So, but on that point of like with your husband, again, it's going back to that preventative, isn't it? If they did it as a standard test at your annual, then in the long run, we're going to save so much more time and money through the healthcare system because we won't be treating all these people because we'll pick these things up earlier.
And you bring up a good point about payment. I'll just say this. I am not very knowledgeable about the cost of tests and whatnot, but I will tell you this. EKGs aren't expensive. Just like x-rays, they're not expensive either. EKGs aren't expensive. Now, if memory serves me right, now this was some years ago, it was over 10 years ago, believe an EKG cost roughly 25, 35 bucks. So obviously there's inflation and whatnot, but let's just say for the sake of argument, the EKG cost $150. I think getting an EKG that costs $150 every 2 or 3 years is reasonable, because if you catch something then, I mean, Kate, indulge me. I'm sorry. You got to indulge me right now. So I was telling this to some clients the other day. Let's say you have a patient that's elderly, comes into your office. How you feeling, Mr. Jones? Call him Mr. Jones. Mr. Jones. How you doing, Mr. Jones? Oh, I'm okay. I'm just a little tired, but I'm old. So, I'm old, I'm tired. Okay, having any problems otherwise? No, besides being tired, no, I'm fine. Say you didn't get an EKG. You got blood work. Say you checked his thyroid, came back fine. Blood work, he's not anemic. Like every blood work's checking out, looking fine. You send Mr. Jones, whatever name I said, you send that guy away, right? Get an EKG. What if Mr. Jones has diagnostic Q waves? And I know your listeners don't know what that is, but any healthcare professionals, they know what I'm talking about. If Mr. Jones has diagnostic Q waves, he may have had a heart attack. And the reason why he's tired is because his heart is weak and he now has cardiomyopathy. So if you would have gotten that EKG, you might have seen Mr. Jones had, oh my goodness, Mr. Jones, what happened? Did you have an old heart attack? I better send this to the cardiologist. Now Mr. Jones is getting care. When people have heart failure, if we do nothing for them, it's a 5-year mortality rate. That is the same as lung cancer. So because we don't want to spend, and I know I said $150, whatever it is, the cost to manage somebody on heart failure and whatnot is astronomically more. But what about his life? What about his family? What about his kids and grandkids and the people that love him? So it's critical that we put this lens of making sure we're doing everything we can to catch this stuff. Because that could be the same guy where they checked on him and found him and he was dead. Why? Because his heart pumping function was 15% and nobody knew, because he was tired and his blood work came back okay.
So go out and demand your EKGs, everybody. Amazing.
At least every few years. At least every few years, yes.
Yeah, well, I think that's a great piece of advice. And again, coming back to that age thing, I think people don't think they have to worry about that until they hit their 50s or 60s and, until something goes wrong. So I think this may be just, a new piece of advice that people haven't heard before.
Absolutely. Be proactive about your health, be intentional about your health. Um, Make sure you are heard. I always say, people say all the time, well, how do you know that your provider is good or not? Well, it's actually kind of simple to figure out. A good provider is going to listen to you. And when I say listen to you, I mean, if you say you're having a symptom, they believe you. Now, they may ask questions about how long does it happen? What's the intensity? Does it happen with certain activity? But I mean, a provider that's not very good is going to say, oh, I'm having chest pain. And if they say something like, oh, it's probably just indigestion. No, that's not a good provider. You should be investigating that to figure out what is going on. So you want to go to a provider that's going to ask questions. You want to go to a provider that is going to explain things to you in English. Not, I know I said cardiomyopathy, but cardiomyopathy just means a weak heart. You want to make sure the heart is strong, because if it's weak, like I said before, it's a pump. Blood's either going forward or backwards, and you don't want the blood going backwards. That's a problem. So someone who listens and somebody who explains things and someone who's thorough. That's what you want.
I know that's very good advice for people listening in. And I know sometimes that can be hard to find. So sometimes you may have to change, doctors, providers to find someone else. Speaking from personal experience and having friends, especially in the female health space, they have definitely experienced that when it's come to, pain and issues. And it's turned out to be cancer. It's turned out, and they've been sent away saying, oh, there's nothing wrong. You're constipated, or this, that, and the other. It's that time of the month. So I think really, like we were saying before, if you have a regular doctor and you can build up that rapport with them, and they know your history, then you're going to have that better sort of, relationship and trust there. So then you get taken seriously, and they follow through and really explore things when they should.
Absolutely. You want somebody who's an advocate. You want somebody who's questioning you. You want somebody on your team saying, okay, well, you're having this. Let's figure out what we're going to do to get to the bottom of it.
So I think that's a really good place to end our conversation on. So if listeners would like to reach out and connect with you and find out all the things you're doing, where can they do that?
Yes. So I have a website, drgthenp.com. I'm on Instagram, drgthenp on Instagram. I'm also on Facebook, drgthenp.com. What I do is I provide lectures on EKGs and cardiology topics to nurses and nurse practitioners. Matter of fact, if anybody wants to pass my information, if you know a nurse or a nurse practitioner, I have a coupon code POD40, POD40. You get my first entry-level course 40% off.
Amazing. Well, we'll link that all up in the show notes too. So listeners, head on over to the show notes. Thank you so much for this conversation today. It has been amazing. And I know listeners, listening in will have drawn so much great information from it.
Well, Kate, again, I want to thank you for your kindness, your graciousness, having me on your platform. It's been an honor and a privilege, and I'm humbled to be here. So I just thank you for your time.
Thank you.